there, my name is Sherilyn Houle and I'm going to be presenting today a quick overview on some hot topics in the area of travel health. In terms of an overview of what we're going to cover today, first we will look at some travel trends and see where our patients are traveling and if that's changing over time. We will also briefly go over some of the key points associated with the new traveler's diarrhea guidelines that were just published in 2017, as well as go over the yellow fever vaccine shortage situation. So let's talk first about travel trends. So other than your patients who are snowbirds, looking at the areas below indicated on the map, where are your patients most commonly going for leisure, business trips, or to visit friends and relatives? I'll give you a couple moments to think about that. So now that you've had a moment to think about where your patients are traveling and where you get the most common destination-specific questions for, I will go over a study that was published in the Journal of Travel Medicine earlier this year, which looked at global travel patterns currently, as well as predicting them into the future up to the year 2030. So looking at travel in 2015 by the numbers, there were 1.2 billion international tourist arrivals in 2015 alone. And this marks the 6th consecutive year of above average growth in international tourism. So those of us who are on social media and seem to notice that everyone that we know is always on vacation or traveling somewhere, it's probably a fairly valid observation. Indeed, travel is on the rise around the world. In fact, in the past year alone, so from 2015 over 2014, there was a 4.6% rate of growth in international tourist arrivals that year. The 2016 results were just recently reported and they are down slightly but are quite consistent with this amount. So we're expecting the same trend to continue over the long term. So going back to the map that we looked at earlier, this is what the change in travel patterns looked like for 2015 versus 2014. So we saw an increase in 6% of travel to the Americas as well as to Asia and the Pacific. Europe was right behind at 5%. The Middle East saw an increase in travel at 2%, and Africa saw a decline in travel by approximately 3%. And one thing I want to draw your attention to is the Asia and the Pacific region, because as you'll notice, it covers a very large area. So all of the northern part of Asia, as well as the Southeast Asian islands and Australia. However, the vast majority of this growth was in the Southeast Asia subcontinent region. So that's one area that we as pharmacists can likely expect to be getting a lot more questions about in the future. This study also found that emerging economies are now being visited at a comparable frequency as advanced economies. So in previous years, Europe and the Americas in particular were well traveled, more so for business purposes, but now we're seeing a lot of international travel to areas that are still in developing stages, and we'll come back to that point later. Looking at their projections through to 2030, you will see that they are expecting growth in pretty much every region of the world between now and 2030. The yellow area that you will see there is Asia and the Pacific region. So as I mentioned before, most of that growth in that region is in the Southeast Asia subcontinent. And you'll notice it's the one that's actually got the fastest rate of growth across all of them. It's actually expected that there will be a 51% increase in international tourist arrivals between 2015 and 2030. So very, very common. We're probably going to be getting a lot of questions about travel medicine in our practice. So why might this be relevant to you as a pharmacist? Well, if we've got an increasing number of people who are traveling, plus an expanded scope for pharmacists, we can probably anticipate there's going to be an enhanced role for the pharmacist in travel medicine. We do know from previous survey work that pharmacist confidence is highest in areas such as traveler's diarrhea and OTC products for travel, so things such as sunscreens, insect repellents, things of that nature. However, these destination trends that we're noticing with increasing travel to especially the Southeast Asia region do put our travelers at different risks from what we're perhaps most commonly used to for all-inclusive Caribbean resort type of travel. So this can include having to consider things such as altitude sickness for people who are going to be hiking at altitude, as well as malaria prophylaxis and even some specialized vaccines. And as I mentioned earlier, the increase in travel to emerging economies may impact the patient's access to medical care while they are abroad. So because we cannot guarantee they will have as good medical care abroad as they do at home, prevention becomes especially important. And this is where I think the pharmacist can really play a key role in keeping our patients healthy when they travel. Moving on to our second topic, which is the new traveler's diarrhea guidelines. This was also a recent publication in the Journal of Travel Medicine earlier this year in 2017. I've got the title and reference there in case you wish to dig up the entire guideline. It is about 20 pages long, so it is quite a a detailed read. It's actually a very well written guideline, so I would highly recommend that you review it. But for today, we're just going to go over the top 3 things to note from these guidelines. The first thing I want to draw to your attention is that there's a new classification system for the severity of traveler's diarrhea. You will likely recall being taught in school that we were before asking patients to count how many times they had unformed stools within a 24-hour period and use that as a measure of the severity of their illness. However, any of us who have ever been afflicted by traveler's diarrhea or know someone who has will attest that 1 or 2 severe episodes can be just as bad as 6 or 7 not so severe episodes, right? And the number of times you go to the washroom in a day isn't necessarily directly correlated with the impact it has on your day-to-day activities. So the new guidelines actually recommend classifying the severity of traveler's diarrhea by its level of tolerability or the distress that's involved and its interference with your planned activity. So a much more subjective and much more personalized approach. So the new definition for mild diarrhea is symptoms that are tolerable, not distressing, and do not interfere with planned activities. This is in contrast with previous guidelines that consider that to be 1 to 2 unformed stools within 24 hours. As we go up to moderate, we start to enter the area where it becomes distressing to the patient or interferes with their planned activities. Severe is when it becomes incapacitating or completely prevents planned activities, so where the patient is quite literally confined to their room, or any dysentery, so that would be any fever, any blood in the stool, anything that's above and beyond your more run-of-the-mill diarrhea symptoms is automatically classified as severe, even if it is only 1 episode. And a new category was also added for persistent traveler's diarrhea, which is for symptoms lasting over 2 weeks. The reason why this was added as a separate category is because patients who have these persistent symptoms may be carriers of different bacteria, and actually it would be within our best interest and the patient's best interest to refer them for some microbiological testing to make sure that we are properly treating them with antibiotics that can address the particular bacteria that are involved. So, needless to say, this does require a little bit of judgment on the part of the patient, but I think we would probably all agree that this really does account for some of the different reasons why people travel. For example, an athlete or a business person maybe cannot tolerate any traveler's diarrhea at all while they are abroad. Similar would be a bride at a destination wedding. So that compared to people who are perhaps snowbirds and are maybe spending a longer time there, more comfortable surroundings, and can put up with the mild symptoms, it really does allow for that tailoring of therapy. These new classifications of severity are also correlated with when you decide to treat and with which drugs. So this table right here breaks the symptoms up into the mild, moderate, and severe categories, and also goes over the drug options that are available for each of those categories. So in the mild category, antibiotics are not recommended. This is based on a strong strength of recommendation and a moderate strength of evidence. However, patients with mild traveler's diarrhea can use loperamide or bismuth subsalicylate to manage their symptoms. As soon as we get into the moderate category, then we start to think about using the antibiotics to actually treat the infectious cause. So fluoroquinolones, of course, are one of the more commonly prescribed agents for traveler's diarrhea. However, we're seeing a lot of resistance starting to develop in Southeast Asia. And considering that this is an area of increasing travel popularity, we may be seeing fewer prescriptions for ciprofloxacin, for example, because of this resistance, and probably more of a move towards azithromycin. There's a little bit of resistance being noticed in Nepal, but for the most part, the resistance patterns to azithromycin aren't as bad as those to fluoroquinolones. Rifaximin is another agent that you may not see prescribed in practice very often, but it is one that can be used for moderate diarrhea. It's one that is not absorbed systemically, so if there are systemic symptoms or any severe illness or dysentery, it's not recommended for treatment of that. So that's where we will probably see the fluoroquinolones or azithromycin being used. Another key thing to be aware of is that these guidelines make it very clear that it is perfectly okay for us to recommend loperamide as an adjunct to an antibiotic. And this may be in contrast to what we were taught in school, where we were told not to essentially trap the infectious organism in the GI tract by using loperamide. The current guidelines go over the evidence that shows there really is no increase in risk associated with using those two together, and so it's in fact actually recommended that if they do need that symptom control, to use it in addition to their antibiotic. As soon as we get into the severe category, azithromycin is preferred because of the resistance patterns that are developing to fluoroquinolones, and the fluoroquinolones or rifaximin can be used if there's no dysentery. And we're also seeing a movement towards single-dose antibiotic regimens for moderate or severe traveler's diarrhea. So in this case, a higher initial dose is used, but it's a one-time dose versus a multi-day regimen. The guidelines go into details on exactly what that dosing is. Some additional counseling points that these guidelines brought up were around how we counsel our patients on using loperamide. So the directions that we most commonly give the patients, and the ones that are indicated on the product packaging, say the patient can take 2 tabs right at the start of symptoms, and then 1 more tablet following each loose stool afterwards, to a maximum of 8 tablets a day. However, there is a bit of a catch involved in that it can take 1 to 2 hours for loperamide to reach its therapeutic effect. Now, if a patient has, let's say, 3 or 4 episodes in an hour and take 4 tablets in that hour, we're probably going to actually cause some rebound constipation, which is going to be equally problematic. So we should really be counseling our patients that the 2-tab stat is the way to go, but give it about an hour or so, and then after that, if there are still issues, then you can take 1 thereafter with each loose stool. But you certainly don't want to be taking a whole bunch all at once and potentially causing constipation. In the treatment of mild traveler's diarrhea, what I think is great news from a practical standpoint is that loperamide has stronger evidence than bismuth-subsalicylate, which, for anybody who has tried to take bismuth-subsalicylate on vacation, it's 4 times a day dosing. You have to take a ton of tablets in order to last through the duration of the travel. So if we're going to be recommending one or the other to the patient, it seems like the recommendation is that we go with loperamide. In terms of reducing the duration of illness, so a patient who has traveler's diarrhea and takes an antibiotic can expect their illness duration to reduce to about a day and a half. However, if we add in the antibiotic with loperamide as adjunct, it cuts it down to only about half a day. So not only is it not harmful to use loperamide along with an antibiotic, it probably actually results in a quicker resolution of the symptoms. And finally, the guidelines also made it clear that there is currently insufficient evidence to recommend the use of any commercially available prebiotics or probiotics to prevent or treat traveler's diarrhea. So if patients do come in with questions about it, we can tell them there's insufficient evidence to show that it does make a difference, and they're probably better off using your normal water and food precautions to minimize their risk of exposure. So going back to antibiotic resistance and the tailoring of therapy, one thing that I was quite shocked to read was that up to 10% of travelers can carry multi-drug resistant organisms for a year, and these can be transmitted to close household contacts. So when we look at the tailoring of therapy and personalization of therapy, we should also be considering who their close household contacts are. If we're especially concerned about them having any immunosuppression or risk of there being any complications from this person potentially bringing back some multi-drug resistant organisms, we may be more inclined to recommend that they use the antibiotics sooner rather than later. As mentioned before, azithromycin is the recommended drug for use in Southeast Asia, and we can look at fluoroquinolones, azithromycin, or rifaximin for all other areas. And at the bottom of this slide, I have included a image that was included in the guidelines that I think is really helpful, that we can provide to patients to kind of remind them of this when we're providing counseling or when they should take their antibiotic. So it goes over what is considered to be mild, moderate versus severe symptoms, and what their treatment options can be for each. You'll notice that the wording does change into the moderate and severe categories. So for moderate category, may use antibiotic is used, and for severe category, should use antibiotic is used. So there is a distinction between when the patient should be considering taking their antibiotic, for sure. And as mentioned before, there is a trend towards trying a single dose antibiotic regimen, and if that's not effective within 24 hours, then the patient can proceed on to the complete course of therapy. So from what I understand, a number of clinicians are prescribing actually enough tablets to provide a single dose regimen as well as to finish a multi-dose regimen as well. So if the option is there that if the single dose is sufficient, they can stop. If it's not, they can finish the remainder of what would normally be the complete course of therapy. Finally, we'll move on to a discussion about the yellow fever vaccine shortage. So yellow fever is a mosquito-borne virus that primarily affects South America and Africa. The areas indicated in yellow there are the areas where it is currently present. The illness can range from flu-like symptoms all the way up to severe hepatitis and hemorrhagic fever. So even though there's a relatively low risk of transmission, so in South America we're looking at about 5 cases per 100,000 people and about 50 cases per 100,000 people in Africa, the mortality rate of 25 to 50% is what really warrants protection through the vaccine. In terms of how the vaccine works, it is 90 to 100% effective, and protection is in place after 10 days. So we need to make sure our patients are receiving their yellow fever vaccine at least 10 days before they travel to a yellow fever area. Some of the countries that are affected by yellow fever have mandatory vaccination requirements, so the traveler must present a certificate of vaccination when they enter the border. However, if there is a contraindication or the risk outweighs the benefit of the vaccine, they can be issued a letter of waiver. And this basically informs the border agent that there is a reason why they haven't been vaccinated. The health professional who made that decision is the one who signs off on that and provides their contact information. It's not a guarantee that they will still be let into the country. However, it does at least let the border agents be aware that the patient did seek out vaccination and it was decided not to because of contraindication. The specific contraindications are age under 9 months, patients who are pregnant or lactating, patients who are immunosuppressed, so for example, chronic steroid use of 20 milligrams of prednisone per day or higher, or anaphylaxis from egg. Those are all valid contraindications, in which case we wouldn't want to give the vaccine and instead issue a letter of waiver. It is a live attenuated vaccine, so we must consider when this vaccine is given in relation to other vaccines. And if the patient is currently on a biologic, obviously we don't want to be giving them a live vaccine. One further thing to remember is that the stopper of the diluent vial does contain latex. So while most stoppers are starting to become latex free, this is one vaccine that does still have latex. So I would recommend if a patient has a latex allergy that they either be vaccinated in a medical clinic or hospital where they can be more closely monitored, or a letter of waiver be issued for these patients. Now let's talk a little bit about the yellow fever vaccine shortage. So there has been a long-standing shortage now for quite a while of the yellow fever vaccine. It's especially problematic for patients who are traveling to Brazil because there is currently an outbreak going on in Brazil, and so the full dose is recommended for travel there. So obviously when we're in the middle of an outbreak and we need to give the full dose, this becomes where we would perhaps want to prioritize the limited supply to. For travel to all other areas, the current guidelines are actually recommending that a fractional dose be given at 1/5 of the usual dose. So it's also given subcutaneously, but you would be giving 0.1 mils instead of 0.5 mils. So in this regard, you can essentially get 5 patients vaccinated for what would normally be a single dose at the full regimen. This has to be planned for very, very carefully because the drug has a short stability. So as soon as it's reconstituted, it must be used within 1 hour. Because we can get 4 to 5 doses per vial, I highly recommend booking multiple patients who require this vaccine together and have them all come in for the same 1 hour period and receive their vaccine to minimize wastage. Of course, the only real limitation with the yellow fever vaccine is that it must be given at least 10 days before travel, so it can be done quite far in advance, and hopefully if you have a busy enough travel practice or you have a family that's coming and going to an area, you can hopefully get 4 to 5 doses out of each vial at once. That said, if you are unable to get 4 to 5 patients vaccinated within 1 hour of reconstitution, we really don't want the vaccine to go to waste. So whatever you have in the vial should be equally divided up among the patients that you do have available. So if you have 2 patients, they each get a half a dose, rather than giving them each 1/5 of the dose and discarding the rest. And as with a full dose, a fractional dose is considered to be protective for 10 days after it's administered. The only thing we don't necessarily know as well is how long the protection lasts. So we do know that the full dose is protective for life. It used to be considered a 10-year vaccine, but it was actually just updated by the World Health Organization and the CDC in the US last year to be considered a lifetime certificate of vaccination. So it's no longer considered only effective for 10 years. We don't have to give additional doses every 10 years to provide lifetime protection. So what was recommended is that we give patients the fractional dose for now that we're at the point of having a shortage and having to ration the supply. However, if the full dose becomes available again, we can give them the full dose as soon as it's available. So we don't have to wait for a minimum amount of time to pass. We can give that dose as soon as we have it, and then they will be protected for life and they can be issued the certification of vaccination. In terms of documentation, the International Certificate of Vaccination or Prophylaxis is a card that is issued to yellow fever vaccine providers, which is the legal document that indicates that a patient has received vaccination. Now, it should not be filled in unless the patient receives the full dose. So if a patient receives a fractional dose, they should not be issued the certificate of vaccination. Instead, they should be provided with the certificate of medical contraindication to vaccination And instead of saying that they're contraindicated to receive it, you would say that they received a fractional dose of the vaccine due to the severe shortage. And that's considered to be the best way to communicate that they do have some protection, but not necessarily complete protection to yellow fever. And as discussed earlier, being a live vaccine, we do have some concerns with it being used along with biologics. So I'm just providing for your reference a table that I found at a very helpful resource. The website is listed at the bottom of the screen. It's provided by Alberta Rheumatology, and they talk about when we should be spacing out our live vaccines and biologics based on the half-life of the individual biologics. So a very, very helpful resource if we do have patients in that scenario. Finally, in terms of keeping current, I provided screenshots of a few resources that I use to keep myself current on this topic. So the Public Health Agency of Canada does allow you to subscribe to travel health updates, which are sent to your email inbox. This includes any notifications of new outbreaks that we need to be concerned about, or travel warnings that are issued, as well as any updates to the CATNAT guidelines. The Journal of Travel Medicine also has email alerts where you can receive a table of contents every time a new issue comes out. And the CDC website does also provide email updates similar to the Public Health Agency of Canada. So all of those can be very helpful ways to keep on track of new and emerging trends in travel medicine. Thank you very much.